Hi there, my name's Laura, and thank you for joining us for this webinar on immune-mediated polyarthritis. These are a few of the topics we're hoping to cover in this webinar. So we'll go through the pathophysiology of immune-mediated polyarthritis, inflammatory and non-inflammatory polyarthropathies, erosive and non-erosive IMPA, and then different types of immune-mediated polyarthritis, and we'll particularly focus on idiopathic immune-mediated polyarthritis and go through some of the clinical signs, diagnostics, treatment, and prognosis. So just a broad overview of the pathophysiology of IMPA. Generally, we consider it to be a type 3 hypersensitivity reaction, where we get immune complexes accumulating in the joint space, and this activates the complement reaction along synovial membranes and causes a spiral of inflammation. And with the release of cytokines and the attraction of neutrophils, we get a further release of cytokines and lysosomal enzymes, which cause tissue damage. So another overview of the pathophysiology, we can get those complexes forming because of antibody and antigen complexes, and they can be viral antigens or bacterial ones, or ones produced by neoplasia. And then in some types of IMPA, we can also get antibody and self-antigen complexes, such as anti-nuclear antibodies produced with SLE, or rheumatoid factor, which you can get with rheumatoid arthritis. And this is just a schematic illustrating the sort of pattern of inflammation within the joint space and how it occurs. And we can also get macrophage recruitment eventually and a release of nitrous oxide and free radicals. So just an overview of other arthropathies that might present to us and might look similar to polyarthropathies. Non-inflammatory arthropathies are things like degenerative joint disease, OA, which we're all quite familiar with and shown by the X-ray in the picture. And then joint trauma, hemarthrosis, and neoplasia can all cause non-inflammatory arthropathies. And there can still be some inflammation with the joint, but we don't typically define them as inflammatory arthropathies. And then inflammatory arthritis can be divided into 3 different types. So we can have infectious forms, non-infectious and erosive forms, and non-infectious and non-erosive forms, which is what we'll particularly concentrate on today. So just an overview, infectious arthropathies can be quite hard to differentiate from immune-mediated arthropathies, and these are some of the pathogens that can lead to them. So definitely we can get bacterial, fungal, protozoal and viral pathogens causing polyarthropathies. And some of the rarer forms, which fortunately we don't see too often, can be associated with bacterial L forms. And this has been described in dogs and cats, but mainly cats that have a subcutaneous abscess near the joint, and that can contain L-form bacteria, which can cause a polyarthritis. To diagnose that, you need to use a special L-form media culture. So it's just useful to know about in case it's something you're suspicious of. And then our tick-borne diseases, fortunately less common in this country, although do occur, particularly in dogs with a travel history. So Borrelia or Lyme's disease, Anaplasma, Rickettsia, and Ehrlichia can all cause polyarthropathies. And in most of these cases, they tend to respond to doxycycline quite quickly, so that usually occurs in about 72 hours. And typically it's recommended to treat them for around 4 weeks with doxy. Mycoplasma species can also contribute to polyarthropathies, and Mycoplasma spumans has been found in some greyhounds with polyarthritis. Mycoplasma felis has also been documented to cause polyarthropathies in cats, and it's always really important, if you are suspicious of that or find it, to also test them for FIV and FELV, as immunosuppression can make this more likely. And then just to recap again, fungal diseases, fortunately less common in this country, but can have an impact on joints, and they can either cause direct joint involvement, and you can get a fungal osteomyelitis, or cause reactive polyarthropathies. And then leishmaniasis as well, something we're seeing more commonly in this country, can cause both a reactive immune-mediated polyarthropathy and erosive arthritis as well. And then something that's really important to make sure we distinguish from our immune-mediated forms of polyarthritis are septic arthritis. So typically this will only affect one joint, but it can be seen in multiple joints, and tends to be associated with quite dramatic pain and inflammation at that site. But it is something that we see more commonly in joints that are already damaged, so ones that have had previous surgery, or in cases of degenerative joint disease, so sort of really bad elbows or hips may be predisposed to bacterial arthritis, or if we have an animal that's had a chronic bacterial infection, so a chronic pyoderma or urinary tract infection, it's something that we should definitely think about. And then to go through our inflammatory arthropathies, are non-infectious but erosive ones. Unfortunately, we don't see them too commonly, so this will be quite a whistle-stop tour, but just for completeness, we will go through them. So they mainly include rheumatoid arthritis, erosive polyarthritis in greyhounds, and feline periosteal proliferative arthritis. And erosive IMPA tends to be characterised radiographically by quite severe changes. So we can see a pattern of both osteolysis, but also new bone formation in the joint spaces shown by these X-rays. And you can also get a destruction of associated ligaments. So often they can present with luxation as well and joint instability. Luckily, it's quite a rare form of polyarthritis and accounts for about 1% of canine cases. Can also be seen in cats, but again is quite rare. And this is just an overview of the pathophysiology of erosive IMPA. So antigens, usually referred to as rheumatoid factor, tend to be host immunoglobulins. And antigen-antibody complexes form in the synovium, similar to other forms of IMPA, which causes inflammation and synovial cell proliferation. And then you get release of interleukins and collagenases, which cause bone resorption and subchondral bone cysts to form. And that then leads to granulation tissue or a pannus formation over the cartilage in the joints. And it can be a bit of a vicious cycle. So rheumatoid arthritis is one of the ones we see more commonly, and this tends to occur in small to middle-aged dogs. Generally, rheumatoid arthritis is diagnosed by meeting at least 10 of the criteria that we define it by, and those are kind of extrapolated from human rheumatoid arthritis. So for a dog to be diagnosed with it, we usually say they must at least meet 7 of the criteria, and those include things like stiffness after rest, symmetrical joint swelling, or typically they can get subcutaneous nodules over bony processes or extensive surfaces. And we can also use rheumatoid factor as part of our diagnosis, but unfortunately it's not a very sensitive or specific test for rheumatoid arthritis, so shown by this very wide percentage range. So some dogs will be clinical for rheumatoid arthritis and can be negative for rheumatoid factor, or are not clinical for it but still have it. And cartilage and bone destruction can take place over months to years, so it can be quite hard to diagnose in the initial stages, and often it's only sequential radiographs that can kind of help you make that diagnosis as well. And then erosive immune-mediated polyarthritis in greyhounds is something that's been reported in Australian and English greyhounds, and actually was first reported quite a long time ago, in around 1978. And it usually causes a destructive multi-joint arthropathy. It does have signs similar to rheumatoid arthritis as well, and you can get calcification of periarticular soft tissues. Not all greyhounds, even though they might show signs similar to rheumatoid arthritis, some of them will have very low to negative rheumatoid factor and anti-nuclear antibody titers. And then there was also a report of some of the greyhounds showing signs of arthritis or polyarthritis, also having signs similar to something called Felty syndrome, which is more of a human phenomenon, and it's sort of comprised of this triad of neutropenia, erosive arthritis, and splenomegaly, but that's not something that's hugely widely reported. And finally, of the erosive polyarthropathies, there's feline periosteal proliferative arthritis, which is similar to the other two that we've talked about. And you get this pattern of periosteal proliferation and subchondral osteolysis. And similarly to our other immune-mediated polyarthropathies, it causes an aseptic neutrophilic inflammation on cytology, and that can progress to lymphoplasmacytic inflammation in later stages. Typically, it's been reported to mainly affect male cats, although there are case reports of female cats being affected as well. And actually, the picture on the right is from a case report of a female cat being affected. And then moving on to our non-infectious and non-erosive arthropathies. Different forms include drug-induced, vaccine-induced, and then more breed-specific forms. And we'll touch on systemic lupus erythematosus as well. And then the last two we'll speak about a little bit less, but just for completeness, polyarthritis, polymyositis syndrome, and polyarthritis meningitis can be causes of immune-mediated polyarthritis, and then we'll discuss idiopathic polyarthropathies and their full subtypes as well. So drug-induced polyarthritis is most commonly associated with potentiated sulfonamides and dopamine pinchers, but other drugs that we use in practice have also been implicated, so phenobarb and cephalosporins. And it usually occurs 7 to 14 days after a medication started, but it is important to know it can develop at any time during long-term treatment. So if an animal has been on a particular therapy for a long time and they develop polyarthritis, it doesn't necessarily exclude it from being a drug-induced one. And signs tend to resolve quite quickly after stopping the drug, so usually a week to 2 weeks. And then non-erosive vaccine-induced polyarthritis. So immune stimulation induced by vaccination has been speculated to be a potential cause of polyarthritis. And you're sort of most suspicious of this if there's onset of signs within 30 days of vaccination. Reported cases have shown a recovery in about 1 to 2 days, and often just with NSAIDs rather than immunosuppressive therapy. There was a paper in 1991 as well linking the distemper vaccine to rheumatoid arthritis, which isn't hugely widely reported. And then there's non-erosive juvenile onset polyarthritis of Akita's. And one of the biggest instances of this was a case report of Akita puppies that developed polyarthritis signs and potentially linked to a recent vaccination. And the typical age range was slightly younger than we see for other forms of polyarthritis, so 9 weeks to 8 months old. And these dogs generally had signs associated with polyarthritis, so swollen joints, joint pain, and pyrexia. But they did also have a certain amount of neck pain, and CSF taps revealed a sterile suppurative meningitis, similarly to other forms of immune-mediated polyarthropathies, joint fluid revealed neutrophilic inflammation. And then there were also some findings on hematology and biochemistry listed at the bottom here. Then non-erosive familial Shar-Pei fever is something we're becoming more familiar with, and the prevalence is estimated at about 23%, which I think can differ geographically among Shar-Pei populations. Usually occurrences of it tend to occur before they're 18 months old, and it's theorized to be linked to degradation of high molecular weight hyaluronic acid within Shar-Pei skin, causing a release of interleukines. And this can be quite difficult to diagnose because it can present with a range of signs other than just swollen joints. So while they can show a polyarthropathy, they can also present with pyrexia, abdominal pain, diarrhea, and even muscle or pleural pain. So it can be quite hard to localize the problem in these dogs. And in worst case scenarios, this can lead to renal failure due to amyloidosis as well. And then lupus, systemic lupus erythematosus is another potential cause of polyarthritis, and it's generally caused by dysregulation of the immune system leading to complex formation. and that can be through pathogenic immune complexes and autoreactive T cells. Some breeds have been shown to be predisposed or have a genetic mutation that can predispose them, like the Nova Scotia Dachshund Retriever. Non-erosive polyarthritis is usually the most common presenting signs of SLE, but can actually present with an array of clinical signs, including oral ulceration and pyrexia of unknown origin. And you can also see thrombocytopenia, an anemia, lymphadenopathy, and even pericarditis with these cases. Typically, animals tend to be affected between 3 and 7 years old, and it can affect cats and dogs. And diagnosis can be based on clinical signs and seropositivity for anti-nuclear antibodies, although that's not unfortunately a fail-safe diagnosis. So sometimes we say if animals have over 3 major signs consistent with SLE, we can diagnose them based on that as well. And synovial fluid analysis reveals very similar findings to other forms of immune-mediated polyarthropathy. So usually we have over 10% neutrophilic inflammation. Then just quickly to touch on these other 2 forms which have been documented. So polyarthritis and polymyositis syndrome has previously been reported in spaniels, and these dogs can present with myalgia and signs consistent with polymyositis or polyarthritis. And diagnostics tend to be very similar as they are for other forms of polyarthritis, so arthrocentesis and a thorough workup, but you can also perform muscle biopsies, or electromyography has been used in the past to diagnose it. And then polyarthritis meningitis syndrome, I put in brackets SRMA, although it's not the same thing, but can be related. So some dogs who present with signs of polyarthritis will also have signs of steroid-responsive meningitis, arteritis, and breeds in which this has been shown to occur in our boxers, Akitas, and Bernese Mountain dogs. And they typically will have signs of polyarthritis, but can also have neck pain, a peripheral neutrophilia, and neutrophilic pleocytosis on CSF taps as well. And then moving on to the main focus of this talk is non-erosive immune-mediated polyarthritis. And we have 2 main classification schemes for this. So one is primary IMPA, which is idiopathic and we don't know why it occurs, and then secondary IMPA, which we say is due to underlying causes. And then the next 4-type classification scheme is just breaking that down a bit more. So type 1 is idiopathic, type 2 is in relation to a distant infection or inflammation, and that can be anything from urinary tract infection, pyoderma, or pyometra, and then type 3 we can see associated with gastrointestinal disease or IBD, and type 4 with neoplasia. So moving on to the signalement for IMPA, and most commonly we see it in animals ranging from 3 to 7 years old, but the age range can be much larger, so an older or younger animal doesn't preclude it as a diagnosis. And has been some studies show females are more commonly affected, but there's no confirmed sex predilection. And all breeds can be affected, although some, such as beagles, have a potential predisposition. It is rare in cats, but certainly can occur as well. And clinical signs typically tend to be having a stiff gait, or animals looking like they're walking on coals. It can be one of the most common forms of pyrexia of unknown origin in dogs as well, and sometimes they will present with signs related to pyrexia, or in their owner's eyes related to the pyrexia, so anorexia can be seen. And sometimes the signs can be quite dramatic, from an animal just not wanting to move to much more subtle, so not wanting to go up steps or not wanting to step up or down off the pavement, and they can also have a peripheral lymphadenopathy. Typically, it's the smaller joints, the carpentarsal joints, that are most commonly affected, but can affect larger joints like stifles and shoulders as well. And a physical examination is always really useful in these patients, because it can direct your thought process and your diagnostics and make you more or less suspicious of a immune-mediated polyarthropathies. So looking at the oral mucosa can give you some clues, and looking for things like oral ulceration, which are more common in systemic lupus erythematosus, is useful. Petechiation and mucous membrane colour is always really useful as well. And then checking all joints for range of motion, pain, inflammation, instability, and effusions is really important, and making sure you are happy it's not just one or two joints that are affected, but it is more widespread. And then it's also really important, even if you think pain is coming from the joints, to palpate the whole of the limb and just make sure you check the diaphysis and the metastasis of long bones, which can help you differentiate from panosteitis, particularly in younger dogs, or hypertrophic osteopathy. And then checking for neck pain or resistance that might indicate meningitis. And auscultation, even though it forms a big part of every physical exam, can be useful again. If you have a new murmur, you might be more suspicious of something like endocarditis, which might signify a hematogenous spread of bacteria. And then laboratory diagnostics are really important, as immune-mediated polyarthritis can be a bit of a diagnosis of exclusion, particularly if it's idiopathic. So, and we want to check for any causes of reactive polyarthritis as well. So a full haematology and biochemistry is always really useful and indicated, and a blood smear, including a platelet count for your cells in-house, is really useful, especially if we're going to go on and do sampling. And then urinalysis and culture to look for any infection which might be causing a reactive IMPA, and also looking for things like proteinuria, which may change your diagnostic plan as well. And then vector-borne disease testing, particularly in our patients who have travelled, is really important to look for primary causes of immune-mediated polyarthritis. So things like a SNAP4DX or Leishmania serology. I think it's definitely still worth doing at least something like a SNAP in a patient that hasn't travelled, because we do see Lyme's disease in this country, and Ehrlichia as well. And then imaging is also a really important part of your diagnostic plan for polyarthritis. So generally you want to do bicavitary imaging to rule out any causes of reactive IMPA or pyrexia. And this tends to include thoracic radiographs and abdominal ultrasonography. At very least, you could perform abdominal radiographs and thoracic ones as well if you don't have access to ultrasound, or if you are lucky enough, a full body CT can also be used, particularly in larger patients in which abdominal ultrasound is more difficult. And I'd also always take orthogonal radiographs of affected joints. It doesn't have to be all joints, but at least two, just so that you can document what they look like initially and look for any erosive changes. And because erosive changes can take up to 2 years to become apparent, it's really nice to have a baseline of what the joints look like. And if at any stage you're becoming more suspicious of an erosive arthritis, then you can compare new x-rays to your initial ones. So arthrocentesis also is an important step in your diagnosis of polyarthritis, and I tend to recommend sampling at least 3 joints. Carpi, tarsi and stifles are the most commonly affected joints, and often you'll only get enough joint fluid to create slide preparations, which is fine. I think it's always useful if you can get a little bit more to put some in a blood culture pot as well, to try and exclude septic arthritis, and also to put some in an EDTA pot for cytology. But equally, if you have only slides, that is usually very adequate. And a 25 or 22 gauge needle can be used with a 2.5 to 3 ml syringe. If you're going to go for a larger joint, particularly in a big dog, you may well need a larger needle, so 1.5-inch needle for the stifle can be used. And then broad anatomical landmarks for sampling the carpus. Generally, the proximal radial carpal joint is the easiest joint to access. And often you'll need to push over a blood vessel and passing over the antebrachium just to avoid that as well sampling. And then the tarsus and the tibiotarsal joint can be one of the easier joints to access, and you can sample it from the lateral aspect along the talus. You want your needle to be perpendicular to the skin, but can be parallel to the axis of the metatarsals. And then just for reference, there's some pictures of x-rays of where you aim to go in. So you can go in along the talus and you'll hit the skin perpendicular with your needle for the tarsus, and then the two of the carpus show where you're aiming for the joint, and often your needle will be sort of perpendicular to the limb as you go into that joint. And generally it's easiest to access the joints if the limbs are flexed by 90 degrees. A 90-degree angle at your carpus and tarsus can open up those joint spaces as well. And once you're in the joint, you want to apply sort of intermittent negative pressure, which you then want to release before you withdraw the needle from the joint space. And that's just to reduce the risk of blood contamination from subcutaneous vessels as you're coming out. If blood contamination does occur and your fluid starts to look a bit more like the tubes on the right, then definitely you can try using a new needle and syringe if you think it's from the subcutis, or using another joint. So often it's easier to start with a carpi and tarsi and then save a stifle and reserve in case you get blood contamination. Arthrocentesis can be performed under sedation or general anaesthesia, depending on how comfortable you feel and how you think your animal will respond. The joints should be aseptically prepared, so clipped and cleaned with dilute chlorhexidine, and then using sterile gloves and drapes can help you to manipulate the limb and get that 90-degree angle of flexion while maintaining sterility. And then a macroscopic evaluation of joint fluid can give you some clues to what's going on, although it is very subjective. So something called the string test or mucin clot test can be used to subjectively assess viscosity. And normal joint fluid tends to be fairly viscous, so it should be able to create a string before breaking if you kind of put it between two gloved fingers or two surfaces, but it is a subjective measure. And then other considerations are whether it sort of looks turbid at all, or the colour of the fluid. And typically diseased joints can yield a bit more fluid than normal joints. However, sometimes you will only be able to get about 0.2 mils from each joint, even if they are diseased, and that's fine too. And then joint fluid analysis, sort of from a laboratory point of view, tends to look at total nucleated cell count as one of our defining factors of whether we think we've got an IMPA. So it tends to be over about 4,500 and up to around 250,000 cells per microliter. Normal joints tend to be less than 3,000, and then total protein as well can help us distinguish between normal joints, immune-mediated polyarthritis, and also septic arthritis. So typically in IMPA we see about a TP of sort of 2.5 to 3 grams per deciliter. And then cytology of joints affected by IMPA will usually show neutrophilic inflammation predominantly, and we really want those neutrophils to be non-degenerate. If we have a population of degenerate neutrophils, we will become a lot more suspicious of an infectious cause, and the fluid can also be assessed for other white blood cells as well, and infectious organisms. So if you are at all suspicious or you have enough joint fluid anyway, it is always really useful to perform a culture. It is useful to know that a certain number of cultures or a certain percentage can still be negative despite infection. So if it's something you're super suspicious of, or you've done in-house cytology and you think you can see some bacteria, a negative culture doesn't necessarily mean from one joint that it is definitely negative. And then treatment-wise, for your immune-mediated polyarthritis, generally the staple is immunosuppressive therapy using steroids. So prednisolone in dogs would be our primary choice, and a dose of 2 to 4 milligrams per kilo per 24 hours initially is usually used. And I know use that until you have a resolution of clinical signs or until you see improvement. And then usually 2 mg per kg for 2 weeks can be used. And this dose can be tapered by 25% every 2 to 4 weeks, depending on how the patient's getting on. Sometimes it will need to be a bit slower if you're suspicious of a relapse, or sometimes they have a relapse after being tapered and it can be increased again. And then in drug-induced IMPA and reactive IMPA, they usually resolve fairly quickly if the underlying cause is treated or removed, and that does depend a little bit on it. So cases of reactive IMPA due to neoplasia might be a little bit harder to treat and may still require immunosuppressive therapy in combination with chemotherapy. And then secondary IMPA, generally treating the underlying cause. So if it's secondary to an infection, can resolve it fairly quickly. And then other immunosuppressors that can be added in addition to steroid therapy include mycophenolate, azathioprine, cyclosporin, and leflunomide. And there are also reports of sulfasalazine being used for enteropathic and rheumatoid arthritis associated with the GI disease. And this is just a summary of other immunosuppressants that can be used and their side effect profiles and mechanism of action and doses. And it can depend a little bit on any concurrent disease processes that a patient has going on and their size and ease of dosing as to which one of these you use. Azathioprine is fairly commonly used, and sometimes economic factors are also a consideration for different immunosuppressors as well. And then in cats, again, steroid therapy is a cornerstone of treatment, but some cats might not respond to prednisolone, so other corticosteroids might need to be used, such as dexamethasone. And then typically chlorambucil can be used as an adjunct, as it says here, at 15 mg per meter squared every 24 hours, or 4 mg per cat per day for 4 days, and then repeated every 3 weeks. And it does depend on your cat size to which one of these you use. Otherwise, you can also give 2 mg every 2 to 3 days. And then ideally, we want to taper that chlorambucil before our prednisolone. And then monitoring of our IMPA patients, if there's no response to glucocorticoid therapy within 7 days, then really we want to start re-evaluating our diagnosis and making sure there are no other causes of the polyarthritis, and also just double check medication administration, which particularly in our feline species can be more difficult, and make sure they are receiving the right dose. And we'd also expect a resolution of previous laboratory abnormalities. So sometimes we can see a hypoalbuminemia, and we'd want those to resolve, as our clinical signs are as well. And then other markers of treatment success can include CRP, so C-reactive protein. And it can be used sort of tentatively. Not all dogs with IMPA will have an increase in CRP, and sometimes they can have a relapse of clinical signs without increases in CRP. But if you have a high CRP initially, it can be quite a useful serological marker of a dog's response to treatment over time. And then also monitoring these patients for signs of infection due to immunosuppression is important as well. And 90% of cases will have a rapid response to immunosuppressive medication. So usually we see an improvement in clinical signs. And then some patients will be able to be completely tapered off immunosuppressants eventually, while others will need continuous treatment. So sometimes we find as you drop doses, a relapse may occur, and they might need to be maintained long term on immunosuppressive therapy. And then unfortunately 10% of patients will also fail to respond to treatment and will have a degree of continued lameness. And also side effects of corticosteroid therapy can influence long-term prognosis, and sort of in terms of how the owners cope with their progress as well. And sometimes side effects like polydipsia and polyuria can affect how well the owners can cope with them at home. And just an overview, one study of canine type 1 polyarthritis reported that 56% of dogs were completely cured and were able to come off immunosuppressive therapy. and 13% did relapse but were subsequently treated. 18% required long-term therapy to maintain remission, and unfortunately 15% were euthanized or died due to IMPA. So just to give an overview of some of the statistics we have. And vaccine and drug-induced IMPA tend to have quite a good prognosis and tends to be unlikely to relapse unless there's repeated exposure. Unfortunately, the exception to this is Akita's with vaccine-induced IMPA, and they can require much more intensive therapy. I think we're at the end. Sorry for the whistle-stop tour. If anyone has any questions at all, do feel free to ask them.
Laura, there was a question that was asked via the chat, so I don't know if you're able to access that. Just have a quick peek.
Yeah, definitely.
Thank you.
Oh yeah, I can see that question for polyarthritis associated with vaccination. Does it occur in young animals or at any age? So it can occur at any age. I think vaccine-associated polyarthritis and Akita's has really been documented to be in younger Akita's, but definitely it can occur at any age in other dogs. And in one study they looked at, I think 4 dogs showed signs of vaccine-related polyarthritis, and they were a big range of ages. Unfortunately, being okay with previous vaccinations doesn't mean they definitely won't develop at other vaccinations. There is tenuous evidence about vaccine-related IMPA. It's definitely something we're suspicious of occurring, but there's not a huge amount in the veterinary literature to support it as well.